Hi, good evening, everyone. Today we'll be talking about the the four major disorder families. So again, welcome to part four of abnormal psychology. So up to this point, we have talked about the foundations of the field, the major explanations of abnormal behavior, and how diagnosis and assessment work. Now we move into the part most students usually expect first, the actual disorder families. But here is the first important reminder. We are not studying disorders just to memorize labels. We are studying them to understand real patterns in real people. That means we are asking, what does disorder actually look like? How does it affect functioning? What tends to contribute to it? How is it assessed? And what kinds of treatment usually help? In other words, we are not doing casual long distance diagnosis. There's not one symptom, one label. Congratulations, I am now a clinician. That is how people become confidently wrong. So, in this section, I want you to think like a careful observer, not just what is the diagnosis, but also what is the pattern here. And we begin with one of the most important and most common clusters in psychopathology, which is, as you already know, mood disorders. Okay. So, how to study a disorder family? All right. So, the best way to study a disorder family is to use the same structure every time. Otherwise, everything starts blending together, and before you know it, every symptom sounds like anxiety, depression, trauma, or sleep deprivation, which, to be fair, is not always easy to separate in college life. So, for each disorder family, ask the same questions. What is it? What are the core symptoms? What is the usual cause? What contributes to it? How is it assessed? What can it be confused with? And what usually helps? That structure matters because symptoms overlap. Low energy can show up in depression, burnout, grief, trauma, even anemia, and a lifestyle built entirely around caffeine and regret. So, poor concentration can appear in anxiety, ADHD, depression, sleep deprivation, and stress. So, the symptom alone is not the whole story, the pattern is the story. And if you remember that, you will understand abnormal psychology much more clearly and much more easily. So let's talk about the first section, mood disorders. Okay, we begin with mood disorders because they are common, impairing, and often misunderstood. Okay, so mood disorders involve disturbances in emotional life, but they do not affect emotion alone. They also affect energy, motivation, concentration, sleep, appetite, decision making, relationships, and daily functioning. This is where people often oversimplify. They think mood disorders just mean sadness or being moody, but clinically it is much bigger than that. A person with depression may say, I feel empty, I cannot focus, nothing feels enjoyable anymore, or everything feels heavy. While a person with bipolar symptoms may not say, I think I'm manic. They may say, I barely sleep but I feel amazing. I have 10 plans at once, or I have never felt more powerful. So, the key point here is this: mood disorders are not just emotional states, they are full system disturbances that affect how a person feels, thinks, acts, and functions. And that will lead us to depressive disorders that are marked by a pattern of low mood, loss of interest or pleasure, and related emotional, cognitive, physical, and behavioral changes. So, this can include fatigue, poor concentration, guilt, worthlessness, sleep changes, appetite changes, slowed thinking, irritability, and withdrawal from other people. This matters because depression does not always look dramatic. Sometimes it looks quiet. It looks like someone no longer replying, no longer caring, no longer enjoying things, no longer believing effort is worth it. So that is also why depression is so often misunderstood, because sometimes people may call it laziness, weakness, or lack of discipline, but depression is not simply a bad attitude. It affects the person's whole operating system. The emotional part is real, but so are the changes in thinking, energy, motivation, and functioning. Then we have major depressive disorder or MDD. It involves one or more major depressive episodes. Okay, that usually means at least 2 weeks of significant symptoms such as depressed mood, loss of interest or pleasure, fatigue, sleep problems, okay, appetite changes uh, is included in that, okay, poor concentration, feelings of worthlessness, and sometimes thoughts of death or suicide. Now, here is the important distinction: MDD is not just sadness. Sadness is a normal human emotion. Major depression is a syndrome, a pattern of symptoms that becomes persistent, impairing, and difficult to interrupt. For example, a person may stop attending class, stop answering text messages, or simply, messages, stop taking care of basic tasks, even hygiene, and start feeling that even small things require too much effort. That is very different from I had a bad weekend, right? So the key point is this: major depression is not about feeling sad for a while. It is about a sustained collapse in mood, motivation, and functioning. And now we'll go to persistent depressive disorder. Okay? In persistent depressive disorder or PDD, it is a more chronic form of depression. The symptoms may sometimes look less intense than in a major depressive episode, but they last longer and can gradually become part of the person's daily life and self concept. That is what makes this disorder so tricky, because a person may start to think, maybe this is just my personality, or this is just how I've always been. Other people may also miss it because the suffering is steady rather than dramatic. And a useful way to think about it is this: major depression may hit like a storm, but persistent depressive disorder can feel like living under permanent gray skies. You still function, maybe, but without much light, energy, or hope. So, the most important point here is that chronic suffering can be easy to normalize, and that is exactly why it can go untreated for too long. And yes, of course, we have bipolar and related disorders, okay, which involve episodes of depression, but also periods of abnormally elevated, expansive, or irritable mood, along with the increased energy or activity. Again, keyword abnormally elevated, all right? And that is what makes them different from depressive disorders. This is important because bipolar disorder is one of the most casually misused terms in everyday life. Someone is cheerful in the morning and irritated in the afternoon, and suddenly people say, maybe I'm bipolar. Okay, that's not how bipolar disorder works. So please, clinically, bipolar disorders involve more distinct and significant shifts in mood, energy, activity, and judgment. And these shifts can include mania or hypomania, where a person may sleep less, talk more, act impulsively, feel unusually confident, and then take risks or become grandiose. So the key point is this: bipolar disorder is not ordinary moodiness. It involves episodes of abnormal mood elevation that affect behavior and functioning in major ways. Now let's talk about mania and hypomania, right? So mania is a period of, again, abnormally elevated, expansive, or irritable mood with persistently increased energy or activity. A person in mania may sleep very little, right? Talk rapidly, jump from idea to idea, become highly distractible. They feel unusually powerful or brilliant, and they would engage in risky behavior such as perhaps reckless spending, impulsive sex, unrealistic plans. Whereas hypomania looks similar, but it is less severe. It is it still involves elevated mood and increased activity, but not to the same degree of impairment as full mania. There is usually no psychosis, and the person may still look functional on the surface, and that is what makes hypomania tricky. It can look impressive at first. The person may seem productive, charismatic, confident, creative, and full of energy. And everyone says, wow, they are thriving. Meanwhile, the brakes are already failing. So, the most important point here is this: not all high energy is healthy, and not all productivity is stability. Now, let's talk about the causes and contributing factors to mood disorders. Now, mood disorders do not come from one single cause. They usually develop through the interaction of biological vulnerability, psychological patterns, stressful life, events, social context, and ongoing habits or routines. For example, some people may have a family history that increases vulnerability to it. Others may carry strong patterns of self criticism, hopeless thinking, unresolved grief, trauma, or chronic stress. Could include sleep disruption, can also play a major role, right? Especially in bipolar conditions where changes in rhythm and routine may have trigger episodes. This is why the question is not usually what is the one cause. A better question is what factors are interacting here. What made this person vulnerable, and what triggered the current episode, and what keeps it going. So that is the key point. Mood disorders are usually not random. They often emerge from a combination of vulnerability, stress, and other maintaining factors. So, suicide is a cross-cutting clinical issue, which means it is not limited to just one diagnosis. Yes, it is strongly associated with depression, but it can also appear in trauma, substance use, psychosis, severe anxiety, personality pathology, and intense life stress. That is why clinicians should never assume that diagnosis alone tells them everything about suicide risk. A person can have depression and no suicidal intent, while another person with a different diagnosis may be in a very serious danger. So, when assessing suicide risk, we look at things like hopelessness, intent, planning. Okay, we also look at past attempts, access to means. Okay, agitation, isolation, and protective factors. This is one of the clearest examples of why careful assessment matters. And the most important point here is simple. If suicide risk may be present, it must be taken seriously, directly, and without vagueness. This is not the place for guesswork, avoidance, or wishful thinking. So that wraps up section A, mood disorder. For the next one, we will talk about anxiety, obsessive compulsive disorders, and trauma related disorders, and that is for section B. So stay tuned for the next lecture series in abnormal psychology that I will upload. Again, I'm June. Thank you so much for listening.